Dr. Richard Siegel trained in internal medicine and he did his endocrine fellowship over 3 years at Tufts Medical Center and subsequently joined the faculty in 1997. At Tufts Medical Center, he is currently the co director of the Diabetes and Lipid Center and is the consulting endocrinologist and bariatrician at the Weight and Wellness Center. In this episode, endocrinologist Dr. Richard Siegel explains the dangers of unmanaged diabetes and what steps you can take to effectively manage your diabetes. He discusses how diabetes management differs between inpatients and outpatients and equips you with some key things to know before you are admitted to the hospital. Dr. Siegel also shares how COVID-19 has improved medical innovation and access to diabetes care.
Podcasting from Dallas, Texas, I am Shireen, and this is the Yumlish Podcast. Yumlish is working to empower you to take charge of your health through diet and exercise and reduce the risk of chronic conditions like type 2 diabetes and heart disease. We hope to share a unique perspective and a culturally relevant approach to managing these chronic conditions with you each week.
Welcome, Dr. Siegel.
Thanks so much for having me.
A pleasure having you on. Diving right in, Dr. Siegel, how did you become passionate about clinical nutrition and diabetes management as an endocrinologist?
So I think this started in medical school, and really a lot of this is about mentorship. And I think it's always important to have good mentors. I recall during the fourth year of my medical school in Albany, New York, the chief of the endocrine division there was Dr. A. David Goodman, who's since passed away, but he really was passionate about diabetes. He also, I think, had trained in nephrology. There's a lot of cross between endocrinology and nephrology, which is kidney disease. And I recall on rounds, we would be going around and he would be calculating out exactly what the change in the blood sugar might be based on how much fluid a particular person might get if they came in with high sugars. And so really he was a thinking man, and endocrinology is a very cognitive specialty. I also had an excellent mentor when I was in my internal medicine residency as well. And this Dr. Stuart Chipkin is still practicing. In addition to doing diabetes and endocrinology, he teaches in the area of kinesiology, which is related to exercise. So really sort of, I think, those couple of mentors stick out in my mind, bringing me to interest in endocrinology, nutrition, exercise counseling, which I also tend to do as well.
Mm-hmm. And then let's talk about the diabetes side a little bit and help us really understand what is unmanaged diabetes and why is it so bad?
So unmanaged diabetes really can wreak havoc on the body. It's what I might call a catabolic state. Catabolism is where the body breaks down, and this can happen in most cases when blood sugars when are over 180 to 200 milligrams per deciliter. To remind you, a normal blood sugar is generally between 70 to 140 milligrams per deciliter. But when the blood sugar gets above 180 to 200 and stays there over days, weeks, sometimes even months, this is what can bring on, for many people, the symptoms of decompensated diabetes, which can include polyuria, so that's frequent urination, and polydipsia, that's frequent thirst. Even polyphagia, as people are losing calories and sugar in their urine, they're tending to eat more. Because they're losing sugar in the urine, they're often losing weight. And with all this, they're feeling fatigue. The most common symptom of anyone coming into an outpatient clinic is feeling tired. And this is definitely one reason why people can feel tired. When blood sugars are in this range, the immune system does not work as well. So people certainly could be prone towards infections per se. So with uncontrolled, unmanaged diabetes, there's slow damage over time that can occur. And this really puts risk to the entire body as blood sugar is really traveling to all the organs. And this is where we think about for the long term, the microvascular and macrovascular complications. That's small blood vessels and large blood vessels. We can also think about diabetes distress, which is a term that goes along with mental health, and really the vicious cycle that can occur between depression and other behavioral disorders and diabetes, and as I said earlier, with infection, really immune dysfunction. The cells that normally are fighting off infection are just not working as well.
Mm-hmm. And what I find interesting here is that it's not something that you feel right away, right? This is something that's slowly creeping up, showing itself in symptoms like fatigue. And it's not something that happens overnight. And yet there's all this stuff happening. And there's very little in terms of symptoms that you can really pick up on there to understand exactly what is going on.
That's right. Really, I mean, when it comes on very suddenly, people may notice the symptoms, but when it's more subtle over weeks or months, sometimes only in retrospect, when I ask, have you been very thirsty? Have you been losing weight? Have you been drinking a lot of fluids? Will people realize that? So I have many patients who may come in and their blood sugars have been 200, 300 for weeks or months. And they to some extent, they're really used to it. And they're often very, very tired, but they've compensated. It's the people who are decompensated, especially when it's happening more acutely, which may happen in the setting of another event, such as an infection. Those are the people that we may end up seeing in the hospital in terms of diabetes consultation, whether they're coming in specifically for diabetes or for another reason.
And so for such folks, what are the different things that they should do essentially to make sure that they don't have unmanaged diabetes?
So thinking about this really involves a team approach. For one, really, I think the basis for all of this is education. And as patients are coming into my outpatient clinic at Tufts Medical Center for the first time, I emphasize that really we want to teach you about what diabetes is. And I do emphasize our team approach. And really, I guess sort of thinking about our outpatient clinic, patients may come to us on their own. So there could be self-referrals, or it could be provider initiated through a primary care clinic, or otherwise, sometimes it's through a specialist. And what we're talking about really at that first visit is a little bit of about what they know about diabetes, and emphasizing the education programs that we have. Sometimes that's one-on-one, and sometimes those are in groups, self-management education programs with a diabetes educator.
And so, how does diabetes management care look and feel differently inpatient versus outpatient?
So with thinking about inpatient, once again, we're part of a team that's helping to manage the patients. Some of the patients are coming in through the emergency room for another reason, and we are consulted because their blood sugars are elevated when they come in. So Inpatient, really, we have a more specific focus, and very often that's really just related to avoiding extremes of blood sugars. So we'll generally say if you're admitted to the hospital, if you're in the intensive care unit, we're actually looking to get blood sugars a little bit lower than we might be if you're on the regular hospital floor. So that range in the intensive care unit at our hospital is usually 100 to 150 milligrams per deciliter, whereas on the regular hospital floor, that may be upwards of about 180 milligrams per deciliter. But still, we want to avoid both hypoglycemia and severe hyperglycemia, as both of those can cause problems when people are in the hospital. The management for patients in the hospital may differ depending on what type of diabetes they have. For a patient with type 1 diabetes, where they're exclusively on insulin, that insulin may need to be adjusted when they come in the hospital. Very often, the doses that are used as an outpatient are going to be very different than what's going to be used in the hospital, because people are eating very differently, or perhaps they may not be eating at all. So for people who are on insulin, we are often readjusting those doses. When people come into the hospital, they should prepare for the idea that their blood sugar is going to be checked by glucometer. And depending on what the situation is, if they're not eating, that blood sugar may be checked every 6 hours. If they are eating, it may get checked before the meal times and at bedtime. Now, some patients wear a continuous glucose monitor, such as Freestyle Libre or Dexcom, and generally that can be continued while it's in the hospital, and that is information that may be very helpful for both patient as well as the care team, and that can be supplemental to what's checked in terms of the glucometer. Really, we're using this information about the blood sugar patterns to help decide on the orders, and the orders may need to be adjusted day to day because things can change very, very quickly in the hospital. I do recommend that patients engage their care team. Really, you should have a good sense of what's going on, how often your sugars are going to get monitored, why they're getting monitored, what the blood sugar goals are, and if changes are being made, why they're being made. Sometimes when people are in the hospital and they may only be getting insulin if their blood sugar is high, and that can lead to blood sugar staying high if they're eating. So really, when I speak of the team, our patients are an essential part of that team management.
Can you walk us through what special considerations individuals with diabetes might need to take if they're admitted to the hospital?
So when patients are coming into the hospital, they need to be really have a full sense of their medication list, as we are asking what oral medications they're on. We're asking what insulins they're on. It's important that the care team really have a sense of any dietary considerations, as specific diets will be written when they're in the hospital. And if there certainly are any food allergies that are involved, the care team needs to be aware of that.
How has COVID-19 in particular impacted those with diabetes, and then just even overall medical innovation and new access methods for diabetes care?
So with the COVID pandemic, we went at Tufts Medical Center exclusively to televisits for 3 months. So the first 3 months, I was at home and doing televisits for all my patients, and we were really just starting to discover some of the barriers and really finding our way. Now we really learned how to use telemedicine in a better way. And currently I'm doing one afternoon session of televisits per week. Very powerful thing for patients with diabetes through the pandemic and with telemedicine is the use of really the cloud-based technology and software. So this has allowed us to get a sense of what patients' blood sugars are, as well as how they may be taking particular medications. Different software programs and apps include Gluco, which can allow patients either in our office or from home upload to the cloud different glucometers, continuous glucose monitors, and two of the three major pumps. And then there are other websites that are cloud-based, including Tidepool, Dexcom Clarity, LibreView for the Freestyle Libre, and CareLink for the Medtronic products. Patients were using selectively the patient portal to send us information, and portals certainly may vary as to whether they can accept documents or not. So some patients were also using my regular email to get me information as well. We definitely, with the use of televisits, increased our use of education as well as between our clinical pharmacist and our nurse practitioners and diabetes educators. We were using televisits for teaching on pens and injection technique. And I know that some of the companies were doing even pump starts using televisits. And so even now, as the pandemic lessens, we continue to use these resources, and I think it will continue to be helpful. I think the cloud-based technology is really extremely useful, especially for analyzing blood sugar patterns between visits and making recommendations.
Just from your observation, Dr. Siegel, how have you seen COVID-19 impact those with diabetes?
So we realized as patients were getting admitted to the hospital with COVID-19 that it is a very powerful infection for some more than others. So for patients with fairly well-controlled diabetes, they were coming in, and especially if they were getting admitted to the ICU, even if they were not on insulin, they were going on insulin, and their insulin needs were very, very high. So patients were becoming very insulin resistant related to the infection, requiring insulin drips. And it's thought that related to the virus, that some of the so-called cytokines, chemicals that are brought out by the immune cells related to the virus, were affecting the liver and fat tissue and the pancreas, affecting both how the body makes insulin and how it responds to insulin. For others, there certainly has been suspicion whether the COVID-19 virus actually can get into those beta cells of the pancreas that make insulin to actually bring on diabetes. So patients who were not known to have diabetes prior to coming into the hospital may have developed new onset diabetes. And it's possible that some of these patients might have had slightly high blood sugars prior to this, and the stress of the situation ended up bringing this out. As the virus gets better, insulin requirements come down, and occasionally patients who are on insulin, as we tell patients in the hospital, even if you're on insulin, it doesn't always mean that you'll always be on insulin. So thinking about inpatient diabetes, it can really, again, be a very changeable sort of situation as patients transition back out to the clinic. So some of those patients on insulin with COVID-19 may go back to oral medication or potentially back to just lifestyle management alone.
Because folks will sometimes resist getting on insulin just for that sheer reason, but there is a path back from there.
Sure. Yeah. And really, this is where, again, the education comes in, whether it's in the hospital or outside of the hospital, teaching people really that insulin may be needed during times of stress because of the various stress hormones that the body tends to make.
All right. So, with that, Dr. Siegel, we're toward the end of the episode. At this point, I'd love for our listeners to learn more about how they can connect with you and learn more about your work.
So listeners can connect with me through the various social media sites at Tufts Medical Center, including Instagram and Twitter. You can find me on the Division of Endocrinology website through Tufts Medical Center. .org, and certainly I am taking new patients. Again, as was mentioned earlier, I see patients both in the Diabetes Lipid Clinic as well as in the Weight and Wellness Center, where we work with patients who need it for helping to get weight down, and certainly weight management and diabetes may frequently go together. So happy to respond if there are inquiries through the hospital.
Thank you so much for your time. And to our listeners, if you want to head over to our social media, our question of the week for you is to understand, how has COVID-19 impacted either yours or a loved one's diabetes? Head over to our social media on Facebook and on Instagram to answer that question. With that, Dr. Seigel, thank you so very much for your time today with us.
My pleasure. Thanks for having me.
Thank you for listening to the Yumlish Podcast. Make sure to follow us on social media at Yumlish _ on Instagram and Twitter, and at Yumlish on Facebook and LinkedIn for tips about managing your diabetes or other chronic conditions. You can also visit our website, yumlish.com, for even more information and to get involved with all of the exciting opportunities Yumlish has to offer. All of the links are in the show notes below, so please don't hesitate to check us out. If you like this week's show, make sure to subscribe to the Yumlish Podcast, give us a like, comment, or a 5-star review, and share us with a friend. This is Shireen signing off. Thank you again, and we'll see you next time. Remember, your health always comes first. Stay well.